I think that a couple reasons. I think one, ketamine has gotten to be a very popular drug in the pre-hospital arena throughout the nation for several reasons that we'll talk about. I think the biggest probably reason was that of its rapid onset of action. We're seeing these excited delirium, behavioral emergencies, what have you. And the Haldol was working, but it was taking 20, 30, 40 minutes for the Haldol to work. And we were putting these people in reed sleeves and holding them down with 10 people, and then by the time they get to the ED, they're sedated, and the ED personnel are saying, look fine to me, yeah, but they've torn up the back of the ambulance. So ketamine, if you really look at the ketamine, it takes effect in about a minute and lasts about 20 to 30 minutes if you're giving it an IM dose for excited delirium. So I think that's the biggest reason for safety of the personnel, both emergency medical personnel as well as the patient. I think that's the biggest thing. Plus, I think with all of the stigma that we're seeing with opioid use and trying to avoid that, ketamine is an acceptable alternative that really provides great pain control without that stigma associated with opioids. So I think those are the reasons that probably that we in Montgomery started to think about using ketamine. Those are the reasons. But if you really look at ketamine, it's a sedative, it's an analgesic, and it works well in all of that. Like I said, an IM dose of ketamine, a minute, and you got them down, and then they're going to stay down 20, 30 minutes. And you may have to redose them if you've got a long transport time. But, in the urban areas, here in Tuscaloosa, you can most of the time get in the hospital in 20, 30 minutes. The safety profile of the especially from a cardiac standpoint with ketamine is absolutely great, so that it's really not going, as a general rule, not going to reduce your cardiac output. It's going to maintain that blood pressure. I went to an airway course, the Ron Wall's airway course several years ago, and he made the comment that if you are only going to have one look with an airway and you're not really wanting to paralyze somebody, just do a sedative only intubation, which there are some problems with that we've talked about in the past at the state level, but still sometimes you have to do just a sedative only intubation just because you don't want to paralyze somebody. And he said that ketamine was absolutely the greatest drug that you could use because, as a general rule, it's not going to knock their respiratory rate down. They're going to breathe through ketamine. Now, can you get some apnea with ketamine? Absolutely. If you give a huge dose of ketamine, and especially rapid IV push or whatever, you can get some apnea with it. But if you're giving a normal IV dose that we have set out in the protocols, they're going to breathe through that. One good thing about ketamine that we're seeing with excited delirium patients is many times these people, because of all the physiologic changes going on in their body with just with the excited delirium, they're in a sort of hypermetabolic state. And many times these people are hyperventilating, and that's a compensatory mechanism to get rid of some of this hyperdynamic state. Ketamine will let them continue that. Some people will use benzos, Ativan, and I'm guilty of that sometimes, of giving benzos to knock these people down or try to sedate them. And some people will say that really you should not do that because benzos will knock that respiratory drive down and knock that compensatory hyperventilation state down. And when you knock that hyperventilation state down, then these people are going to have like I said, a reduced respiratory rate. They're going to have a reduced respiratory drive, and you're going to knock that hyperventilation compensatory mechanism out, and they're going to have some potential for hemodynamic instability and for some dysrhythmias. So really, ketamine is the drug of choice rather than benzos. Now, I'm guilty of using benzos sometimes too, but really ketamine is a much better drug for that. Pain control, especially if you got somebody that's entrapped. You maybe you can't get to them to manage an airway real well, so you really don't want to knock somebody down and then worry about, well, can I get them intubated? Can I not get them intubated? If you give a low dose ketamine for pain control, then you're not going to knock their respiratory drive down. And it's somebody, especially entrapped, that maybe you can't get to them to really manage an airway like you're supposed to, then that ketamine is going to be great for that. So, again, hemodynamic instability. You got somebody that's an entrapped trauma patient that you're having to give pain control while you're getting them disentangled or extricated or whatever. Ketamine is a great drug for that because it's not going to affect that respiratory drive. It's not going to affect the cardiac system. Is a general rule. Are there some problems with ketamine? Absolutely. I think that you can get some laryngospasm, and that is a very rare circumstance that sometimes you get with rapid IV push, especially high dose rapid IV push. Most of the time these people do not need to be intubated. Just back them through that. That corrects itself. You can get some vomiting, especially with rapid IV push. Some people even advocate giving Zofran or whatever before you give ketamine. Emergence phenomenon, and that's just hallucinations, etc., that they get after ketamine. And sometimes you can get that, and I've seen that once or twice, not a lot. And you can give some benzodiazepines with that to keep them from having the emergence phenomenon and try to keep it, quiet and dark environment. I know that's hard to do in the pre-hospital setting, but those are things that you see. When you give it, sometimes you get hypersalivation. They just start, salivating. Again, you can give a little atropine, and that'll dry some of that up too. That's more along the lines if you're going to RSI somebody. But just for pain control, side delirium, I think ketamine is a phenomenal drug, much better than the Haldol.
Talk about what types of pain to treat with it, and that we sometimes get, the 30-year-old with back pain, with no prior history or no injury, non-traumatic back pain versus elderly person who's fallen and broken a hip. And then you've kind of already spoken to the patient who's entangled in the car. You're trying to manage those kind of pain. So at what point do you try to manage the pain pre-hospital, or what pain would you manage pre-hospital with ketamine?
Personally, I don't think, from a protocol standpoint, I don't think anybody can say, hey, you shouldn't have managed that back pain or ankle pain from sliding into second base at the ballpark. But it just is a sort of a common sense approach. Same kind of stuff that we don't carry morphine, we don't carry fentanyl, but you really ought to think the same line of thought. And if it's an ankle fracture, if it's a humerus fracture, that's fine. But somebody that twisted their back lifting something and they call the ambulance, I probably would not give those people ketamine. I think the hip fractures in elderly, certainly I don't want those people to hurt, but I think you need to be very careful in those old people and maybe not give that dose of ketamine that 0.2 milligrams per kilogram IV or 0.5 per kilo IM. I would third that dose or half that dose, because I said you won't get much respiratory depression, and you usually won't. But all bets are off on these old people. When you get an elderly patient, all bets are off. I have always been of the persuasion that I probably underdose these people lots of times initially, but I've always been under the persuasion that I can give them more, but I can't take back what I've given them. So I like to titrate that medicine to see what it's going to do. Now, I understand after that first dose, you got to call med control, and I understand that, and that's a problem sometimes. But most of the time in the city here, that one dose, by the time we get them to the hospital, they are, we don't have a whole, a long transport time, I guess is what I'm trying to say. And from a pre-hospital standpoint, maybe we need to understand that we're not trying to make maybe the pain go completely away. It's just manageable type pain. So I think the major trauma, femur fractures, pelvic fractures, humerus fractures, ankle, tib, fib fractures, I think all those are fine. Those people entrapped that we're trying to extricate, those people that in an industrial accident, their extremities caught in a conveyor belt, etc. I think those are the kind of people that you really need to think about ketamine. Again, nobody's going to fuss at you about using ketamine for that older lady, older man with a hip fracture, but just be careful with that.
Okay.